Hi, I'm Dr. Eric Westman, and it's my pleasure to be with you at Keto Salt Lake 2021. The talk that I'm going to give today is internet-based versus evidence-based keto. And I'm going to draw upon my background as a professor, a clinical researcher, and then also bring out in some new information and new results from surveys that we've done of classes that we've given recently to see if we can tease out the differences between internet-based and evidence-based keto. I'm an associate professor of medicine at Duke University in Durham, North Carolina, and I'm director of the Duke Keto Medicine Clinic. I have a few conflicts and disclosures. I have published over 45 peer-reviewed papers on keto, although I readily acknowledge there are other ways to go about this, other healthy ways of eating. I'm past chairman of the board of the Obesity Medicine Association, which is the largest group of medical weight loss doctors in the world. They use keto diets, medications, very low-calorie diets, lots of different methods. I'm also co-founder of Adapt Your Life and the Adapt Your Life Academy, which is a company that has keto products and education. I'll talk a little bit about that in more detail in this talk. I'm also author of several books. The most recent one is called End Your Carb Confusion, came out in December of 2020. I wrote that with Amy Berger. You might know Amy from Tuit Nutrition and her Alzheimer's antidote book as well. I helped write Keto Clarity, Cholesterol Clarity, and the new Atkins for a New You. But End Your Carb Confusion brings my most up-to-date thinking all in one place. So check that out, please. You might have seen me as a teacher at dietdoctor.com or at other venues like this, Low-carb USA, Salt Lake, and Denver, and San Diego, and West Palm Beach. I've been teaching this now for about 15 years after doing 5 or 6 years of clinical research trials, all since 1998, when I was first introduced to this way of eating by 2 of my patients at the VA Medical Center in Durham. So I've been in this space for a while. I've seen the traditional teaching of low carb, high fat, LCHF, as you see here. I've seen it morph into the internet confusion we have today, and I'd like to try to help clarify and simplify things for you best I can. Now, you may have seen me for that brief week of the year in 2014 when I was on the cover of Woman's World. That's me. And then a cover of Woman's World again just this last year. And, I have to say, as an academic, this isn't the first thing I tell my fellow researchers that I've been on the cover of Woman's World, except I have to acknowledge that we've probably had more success in spreading the message by helping with the pop culture media transformation into keto being accepted than the research papers that we published starting in 2002, 2004, 2006, 2008. So a different kind of publication, and I do have to say that the title on the cover exaggerates what you expect to find, but the articles inside are really true to what I would normally see. So no, I wouldn't expect you to lose 60 pounds this month as a general rule. Yeah, I've seen that happen, and that is just a way they, I guess, sell the magazine. But the stories inside are really good, and I worked with the writers of both of these, and they were very responsive to getting it right. And thanks to the people like Judy Tucker, who allows herself and her story to be put in this kind of venue. It's very inspirational to other people. So depending on where you've seen me, I've been in the keto world for about 20 years. So what I've seen is that there is currently still a taboo on studying low-carb keto diet. So what does that mean? It means there's no law against studying low-carb diets. I mean, there's no rule against it. It's just there's sort of an unwritten rule that who would want to ever study a low-carb keto diet, right? So I noticed when I was starting to look into this back in the year 2000, or really 1998, that no one had actually studied the keto diet or low carb diet since 1980. So I tracked back into the medical literature, and there had been a 20-year absence of studies on low carb, high fat diets. If you remember back, that's when everyone was saying eating fat was bad for you. In fact, this might be still in your mind because we were all taught that. And it turns out that once studies were done, and Dr. Yancey and I at Duke on the bottom left, Dr. Volek and William Kramer at the University of Connecticut, now at the Ohio State University, started studying. Basically, we both approached Dr. Atkins, and we studied what was known then as the Atkins induction diet, which is pretty much what I use today, just under a different name and maybe some changes over the years. But so we were one of the research teams that started to look at the safety and healthfulness of doing it, or not, whether it was bad. And I have to say that after 20 years of being in this space with now dozens of articles done all around the world, that it is safe and effective, and eating fat is not harmful. And we were all taught that it was. It's really the sugar and the starches that are the fattening foods. And but I understand if you were taught, and if your doctors were taught before this time period, they may still have the preconceived misconception that this is something bad to do. And I still kind of fight that with some of my patients to this day. Yes, I'm still at Duke in clinical practice. So these outpatient randomized controlled trials, it wasn't just us and Jeff Volek, all of these other major authors. Gary Foster was at Penn, and he became director of Weight Watchers for a while, or WW, and Mike Danziger is a general internist, and Christopher Gardner is still a diet researcher at Stanford. Everyone kind of took their crack at low fat versus low carb, and they all found good results with both, but low carb did better as a rule. Of course, we were the only ones that went out, that's the Yancey 2004, second one from the top. We were the only ones that actually visited a doctor who was using a low carb diet. Dr. Yancey and I visited Dr. Atkins in New York City and said, what do you do? And so we studied their method, and you can see on the far right, we had the best weight loss, even though it was similar time period or even less time than some of the others, because we used what I call today the prescription strength keto diet. But these are the evidence-based medicine studies that are done, putting together now series and meta-analyses. There are even obesity RCTs, meaning randomized controlled trials over 12 months, comparing low fat and low carb. And it's not that low carb is the only thing that works. Low fat can work, but for a lot of people it doesn't, practically speaking. But low carb works better. And now this is done in many, many studies. This is called a meta-analysis. On that figure on the right, the line down the middle means there's no difference. The diamond at the very bottom summarizes all of the studies. And if the diamond doesn't cross zero, it means it has statistical significance. And so the studies, you line them up, it favors the low carb, very low carb ketogenic diet. It's called here that it's superior in terms of strength for weight loss than the low fat diet. This was published in 2013. There are now 3 or 4 different meta-analyses like these and finding pretty much the same thing. Dr. Yancey at Duke decided, well, gosh, if low carb works so well, let's compare it to low fat, and better than a low fat diet. Let's compare it to a low fat diet and a fat blocking drug called Orlistat. It was released as Xenical and then Ally over the counter. And it turns out here in a randomized trial among VA, Veterans Affairs, outpatients, people who have medical illnesses, and there were about 146, 150 people in, that in this randomized trial, the diet in red worked as well as or better than the low fat diet with a drug. And so a diet by itself performs just as well as a diet and a drug. The low fat diet and the fat blocking drugs are kind of fading away because they didn't work all that well to begin with. And here now you have a new approach, like a new type of phone or a new type of car that works even better. And I argue that it's even simpler to do, easier to teach, and with the hunger gone, it really makes it kind of simple to do. I'll get into that later. But so still back to the evidence-based studies, RCTs, meaning randomized controlled trials. There's so many of them now. The Public Health Collaboration of the UK.org has a figure that you can download or just look at. Here in the middle, the bars tell you how tall the bar is how many studies there are, comparing in blue, low carb, statistically significant, 31 to nothing is the score compared to low fat in these same studies. So the weight loss is better for low carb over low fat. In fact, it's not even close. If it were a football game, it's 31 to nothing. So it's not even it's a rout. So, but not that low fat diets can't work. They can. It's just low carb diets work and work better. So the body of evidence is so big now that we need figures like this to show all the different studies, and it surpasses the level of evidence that would be required for an approval of a drug. So a certain level, number of studies, number of people who have been in studies is required to have drug approval in the US at FDA. Now, there's no approval process for a diet. And I even wonder maybe there should be, because then a lot of these other things you hear about wouldn't get confusing there in marketing and on the internet. But if the low carb, high fat diet were a drug, it would be FDA approved if there were that process. So when I teach this to my patients, I say, like a prescription drug, this will work if you do it. There's that much evidence behind it. It's safe and effective, like it were an approved drug. And that's my experience over the last 23 years now in academic medicine, watching these studies being done. And so don't worry about whether it is safe or harmful, or it's safe. It's even been incorporated into several guidelines now. Now, there are a lot of doctors that wait for guidelines. They don't look at all the studies themselves. That's okay. I have been on guidelines myself and have contributed to guidelines and contributed to this one from the Obesity Medicine Association. And as you can see here, the very low carbohydrate diet is in the algorithm guideline of the OMA, or the Obesity Medicine Association, that group of doctors who use medical weight loss principles and methods. It's there in the middle, at the bottom, the very low carbohydrate diet, less than 50 grams per day or less, with or without nutritional ketosis. So it's on there in side by side to the restricted fat diet, which can work, and on the far right, the very low calorie diets, which are physician supervised, and you have to purchase those from your doctor. So of all the different choices we have, a low carb diet you can do without any pills, without any products. You can do it on your own with the proper teaching. So switching from obesity to diabetes, which is the next level of information you need to know about. A low carb, high fat diet has been used for over 100 years for the treatment of diabetes. A low carb diet in 1923, here in this book, which on the left was written by Sir William Osler, which is the father of internal medicine. Every medical doctor, internal medicine particularly, knows the name William Osler. And this is from 1923, one of his textbooks that was the prevailing wisdom and the teaching tool for doctors at the time. And you can see in the middle, in the purple box, the quantity of food required by a severe diabetic weighing 60 kilograms, so about 125, 130 pounds, was 10 grams of carbohydrate for the day. And there are 4 calories per gram, so that's 40 calories from carbs, 75 protein, 150 grams of fat, and alcohol. And some of my patients look at this and say, I can have alcohol. Well, you can at small amounts. But remember, in 1923, there was no medication for diabetes. Insulin was discovered, for you historians who remember, in 1921. And it didn't even make it into this textbook that was published in 1923 to just show you how slow things changed back then. But look at the strict diet. The strict diet was meat, poultry, game, fish, clear soups, gelatin, eggs, butter, olive oil, coffee, tea, cracked cocoa. It's basically the same diet that we studied and now I use at Duke in 2021. And, it's sad and it's reassuring and it's terrible and wonderful all at the same time. Because what I teach is nothing new. It's what doctors did before there were medications to treat diabetes. So it's just, I see it that what I do is just a rediscovery of a way that was being used before medications came about. So now there isn't quite as much data and as much evidence for low carb diets and diabetes, but it's growing. And compared to other diets, it's as good or better. So here, the meta-analysis here, called a network meta-analysis, shows the size of the bar and the size of the circle at the end of the bars, give you a relative comparison of different diets, and the number of diet studies and the number of people in the studies. And you can see the low-carb diet on the left, lower left in the middle, has just as much information and studies as the Mediterranean diet for diabetes or as the vegetarian diet for diabetes. So when you compare different diets, there isn't a whole lot of evidence for these other diets other than the low-fat diet, which is the huge one, although it really doesn't work all that well. So the growing number of studies of low-carb diets for diabetes is fast surpassing levels of evidence for the other kinds of diets that we have. Now, one of the pioneering studies that I need to mention in great detail, a little greater detail, is the study that was called The Effectiveness and Safety of a Novel Care Model for the Management of Type 2 Diabetes. This was also known as the Hallberg study as first author, or the Virta Health study, so that they had 262 people with type 2 diabetes. They had overweight or obesity as well. Just about everyone was Caucasian. The ketogenic diet was taught through classes or a web-based program. So they used computer apps on cell phones, and the goal was to get people into nutritional ketosis, hook or by crook, as best that they could. So they had people measuring their blood ketones, their body weight on a scale that was all Bluetoothed, computerized back to the study program people. The computer app even had a doctor that would help you in the phone to de-prescribe or come off the medications, to make sure you get off the medication safely. And what they found is that the hemoglobin A1C went down and medicines were reduced all at the same time. So at 1 year, there was a significant improvement of A1C from 7.6 to 6.3%, and to 7.6 to 6.7% at 2 years. So there was a sustained reduction in hemoglobin A1C. There was a reduction in body weight as well, and diabetes was reversed in 54% of the people and was put into remission in 18% of people with diabetes. This is unheard of as a result. Of course, our study on diabetes was published in 2008 and only had about 50 people in it. It's known as a proof of concept study. This one really was a pivotal trial to show that compared to usual care, nutritional ketosis, using this kind of method to teach people, is really unparalleled. It's fantastic. Not only do you improve A1C, you reduce the medications, and you can reverse diabetes. There's several papers. The Athanarian in Frontiers in Endocrinology has the 2-year data, and it's still significant and reduced from 7.6% A1C to 6.7%. Now, what's kind of hidden in those averages is some people have A1Cs then under 6% in the fives, and they're off medicine, and that's diabetes reversal. So what I have started to tell patients who come to me is, did you know you can reverse your type 2 diabetes? And very commonly, they don't know that. Most doctors still tell their patients you're always going to have diabetes. It's sad, but that's the state of affairs. So the evidence for diabetes isn't quite as much as for obesity, but in 2019, the evidence was incorporated into a guideline paper from the American Diabetes Association. So a very low carb diet is supported by the American Diabetes Association to be used for diabetes. So if you're going to be waiting for a guideline, or specifically waiting for the American Diabetes Association guideline, you have to wait no longer. And side by side, other types of diets, including the low carb diet, are in there. And you want to use it, of course, with monitoring if you're on medications, like any sort of dietary approach. And, it's taken to 2019 for a guideline to incorporate what was done in 1923, which, however you want to look at that, it's ironic, it's sad, it's terrible, it's great. Finally, we have kind of back to the future, as you will, or back to the past. Now, the nuance of treating diabetes with a low-carb diet is everything gets better except one thing. So this is the Hallberg, the Verta Health paper, looking at all of the different parameters in the blood, and Banpuri et al. Is the 2018 is the paper, and this is a figure from that paper. And you can see at the very top, the kilograms went down, meaning it went to the left. If you look way at the bottom, 0, the line in the middle means it didn't change, and then down 10, 20, 30% going that way. So clinic weight down kilograms, that's the direction you want. Hemoglobin A1C down, going to the left, blood pressure going down, systolic and diastolic, ApoB. ApoA1 is actually okay to go up. ApoB, ApoA1 going down, the ratio you want it to go to the left, triglycerides to the left. And the one thing out of all of these things that went to the bad side, or the going up when you want it to go down, is the LDL cholesterol right there. So it's okay because everything else is getting better if there is an isolated elevation in LDL. And we see this in maybe a third of people who follow a low carb diet. So actually 2/3 of people will have a reduction in LDL. So all of the other doctors who just look at LDL will be happy. But then, a third, I need to talk to them about the triglyceride, the HDL, the metabolic syndrome, and many of them have never heard of that. And so actually we treat and reduce cardiometabolic risk by targeting the metabolic syndrome, not necessarily the LDL. So this is not worth to bail out or worry if your LDL goes up a little bit or a lot of it. And there's actually a group of hyper responders who are studying themselves because everyone else wouldn't study them. They told them just don't do it. And they're studying themselves. That's Dave Feldman, the Cholesterol Code, and the Facebook group Lean Mass Hyper Responders. And the sad state of affairs today is you have to raise your own money to study yourself if you're doing something so radical that was done 100 years ago before there were drugs for diabetes. This is just kind of the awkward position I'm in as an academic. Another way to put it, Jeff Volek has studied now at UConn, University of Connecticut, and now at Ohio State, the metabolic syndrome, paper after paper after paper. The low carb diet targets the metabolic syndrome, and that's triglyceride, HDL, small LDL. These all go in the direction you want. And here, comparing keto diets with low fat diets, keto meaning the carbs are sufficiently low to generate ketones in the blood and in the urine. Keto diets work better. So low-fat diets can reduce the metabolic syndrome. It's not that keto has a monopoly on this, but keto does a better job at targeting the metabolic syndrome. Putting it in a different way, different kind of figure, keto addresses insulin resistance, which is the underlying root cause of metabolic syndrome. It's also known as carbohydrate intolerance. All of these are basically the same phrase, the same term, synonyms. So the total LDL, old normal, would be just looking at LDL in total as cardiometabolic risk factors, those checks in the middle. The metabolic syndrome, the new keto normal now, we don't care about the total and the LDL cholesterol. We care about the triglyceride, the HDL, the abdominal obesity, that's your waist circumference, the elevated blood pressure, the elevated blood glucose, and thankfully, that's what a low-carb keto diet targets. Now, if you're a historian or just want all the science behind it, look back to the studies down at the bottom right if you can. Jerry Reven at Stanford was publishing about this in 1976 and just wasn't heard over the loud noise of eating fat is bad and total and LDL cholesterol are more important. And Jeff Volek in the past 15 years has nailed this in many different papers, many different ways, so that we want to reduce the metabolic syndrome. Don't worry about the LDL and the total cholesterol, please. When I looked at the evidence-based keto up so far, what these studies are, and trying to compare what people are doing today, I had to kind of remember a few principles of the diet teaching in all of these studies so far. The main message was to limit carbohydrate or carbohydrate restriction, not add fat or eat fat or excuse me, drink fat or so protein is and limiting carbs is the main teaching of the diet programs in evidence-based keto diet studies. These were programs that ensured that the program was nutritionally complete, meaning there was an emphasis on real food, not buying products and drinking oils and pills and things. Real food and protein rather than fat as the primary nutrient. You see, when you're losing your fat weight, when you're using this for diabetes or obesity treatment, the ketones come from your belly fat. They come from your body fat. You don't have to drink ketones to have ketones. You don't have to eat fat to get ketones. You get the ketones from your own body fat. So we weren't giving these people anything to raise ketone levels, and they were generating plenty of ketones on their own just by restricting the carbohydrate. So the term that you'll see a lot, the third bullet here, is a well-formulated, adequate protein ketogenic diet. Not high protein, but adequate protein. So in these studies, going back to ours in 2002, Gunther Boden, 2004, inpatient studies, the ad-lib food intake, when you teach people that's very low in carb, reduces the hunger. And the ad-lib food intake goes down by reducing the hunger in just about everyone. Now, there are ways to thwart that, but this is why this is known as a diet for weight loss. There are very few studies, if any, that have used medium-chain triglyceride oils, added fats, ketone drinks. I've seen apple cider vinegar pills and ketone pills. These have never been studied. These are not part of the evidence-based medicine studies that have accumulated now to FDA approval. Very few studies, although the Virta Health study did involve a computer app. There are very few other ones that used this kind of app sort of teaching. And I see that causing problems in people who just use an app and don't understand the principles of carb restriction. And then the keto measurements, we use urine ketones in our studies, and there are very few studies that have used blood ketone measurements to show that it helps people with weight loss. And so when you're using all of these different gadgets and things, they haven't been properly tested in all these different people. Not that it would change the teaching of the diet. It's just that it can lead you astray. And I'll point out a few ways that can do that. So I kind of reviewed up till now the evidence-based keto diet studies and our general understanding since 1864, William Banting in England, William Osler, Frederick Allen, the early 1920s, using this to treat diabetes. And that's what we know the most about. So we opened the Duke Keto Medicine Clinic because the science was so solid, and I incorporated the science and teaching of doctors who had used this through the 1960s, 70s, 80s, 90s, and the research studies that were done in the early 1900s. I thought those counted. So we've treated thousands of patients at Duke since 2006 using this for treating not only obesity and diabetes, but PCOS, irritable polycystic ovary syndrome, the cause of infertility in women, irritable bowel syndrome, fatty liver, GERD or heartburn, cardiovascular disease, even heart failure, pre-transplant heart failure patients who are on implanted pumps. These are probably the sickest people who are still alive and walking around. And they have this pump going, in their chest, And the heart doctors don't want them on medications. They're already on enough medicines. So they send their patients to me to help them lose weight without pills, without products. Even post-bariatric surgery weight regain can be fixed or ameliorated, helped a lot by using a keto diet. And then weight gain caused by medicines, we can turn that around. More and more, I see people who've been on prednisone for years to treat some condition, a sarcoid disease that's really serious, but they might gain 100 pounds being on these medicines, and we can help in those cases as well. So our method to teach the keto diet is uncomplicated. Protein comes first, and you can run your body on carbs or fat. It's your choice. If you don't eat carbs, your body will run on fat, and it'll find it on your body. And that's why your body becomes a fat-burning machine. So really all you need to do is cut the carbs out and eat some protein and fat along the way. So when you're hungry, we say eat as much as you want of these foods till you're comfortably full. Meat, poultry, fish and shellfish, and eggs. Don't avoid fat in real foods, but don't add fat if you're trying to lose fat weight off your body. That makes no sense. The ketones will come from your body fat. And then we teach people to have 2 fistfuls of leafy greens for the day, not per meal, but the whole day. 1 fistful of non-starchy vegetables for the whole day. And here's the list. And we say, if it's not on the list, you can't have it. These are all carefully selected to be non-starchy foods that are allowed in limited amounts. So this is the clinical experience that we went to visit doctors who had used this and asked, what do you do? And they said, well, you need to limit things like cheese, creams and oils, and mayonnaise because they have a lot of calories and people will overconsume them. Some people, mayonnaise is a trigger food and they'll eat the whole jar. So the common sense kind of street credibility of, here's how you use it in clinical practice is something that we learned from other doctors and incorporated that in our studies and continue to use that today in our practice at Duke. And then 0-carb snacks are basically unlimited because they don't raise the blood glucose, don't raise the insulin. Insulin's the fattening hormone. That's the simple cascade of events you just want to try to limit. You don't want to eat things that raise the blood glucose. So sugar-free Jell-O, pork rinds, pepperoni slices, low-carb jerky, boiled eggs. These are fine as long as they have 0 carbs in them. Now, let's go to internet-based keto. And so, like this poor child, the people hitting the internet today searching keto, it's overwhelming. So I get people coming to the office who are doing their best to understand what to do, and they either give up or they try something that's kind of bizarre and it's not working. So, I had my kind of preconceived notions just by talking to people about internet keto and seeing all these ads come up on the things I use for teaching. But I thought I wanted to explain where this comes from, as I've noticed in this space for 20 years now. We studied this type of diet at the very bottom here called LCHF or LCKD, low carb, high fat or low carb ketogenic diet. It focuses on carbohydrate restriction, total carbs, not net. And that's what the evidence-based medicine for obesity and diabetes tells us. Now, enter in this confusion and the ketogenic diet for epilepsy on the upper left-hand side of this fire hose of information. It brings in the macro focus. You need to have ketone levels and have a ketone meter and all this. And that really comes from the ketogenic diet for epilepsy world, where some children will have a seizure if they have a drop in their ketone level. They have to be very careful in monitoring these things. And so that got adopted by the keto internet community. We can sell a meter, we can teach people to find an app and follow their macros, but I find that can distort people's view, lead down paths that don't work when focusing at the very bottom, the carb restriction. Total carbs, which is what was evidence-based, can fix these things. So you don't have to do all those things. I'll get into that in a moment. The paleo-primal movement, of course, kind of contributed to this information on the internet, and probably for better than worse. But what they've done is introduce the idea of food quality. Grass-fed beef, grass-fed butter. You have to go to the farmer's market, buy half a cow, and share it with your neighbor. It's not keto metabolism. So it might help people who don't need to fix diabetes or fix obesity, that prescription strength keto metabolism. And it's certainly nice if you can to help change the world with your food dollar toward a sustainable world in terms of food production. But many of my patients can't afford it, or they can't understand why they have to have a certain thing. And so we even never really focus too much on food quality, and it still works just fine. So that's why we're so confused today when someone comes to the internet and all of these things are jumbled together. Enter in now testimonials of people who have been in the gym 5 hours a day and do keto, or they're young and they didn't need keto for obesity and diabetes, but they're doing it and they have a big following. And the people who don't have the same metabolism try to follow it and it doesn't work for them. So what I've developed and what the evidence-based studies show will work for just about everyone, because it's keeping the carbs really low and doesn't get distracted by all of these other noises from the internet. So the success that I see is thwarted by internet keto in these ways: that you may have a belief that purchasing a product is necessary to do keto. That's not true. You may have a belief that drinking or eating ketones or adding more fat is needed to get into ketosis. That's not true. Your body, if it has fat on it, the fat will generate its ketones by itself. There may be a belief that measuring with an app is necessary, but that can overcomplicate and lead to following the app rather than your body signals. So I've seen people say, well, my app said I had to eat more protein, or my app said I had to get my macros right. No. If that's working for you, great. But if it's not, then there's a simpler way, like we teach. And then keto becomes complicated and confusing and maybe even costly if you get thwarted and distracted by internet keto, not evidence-based keto. So I wanted to get a little more data, and I like presenting data. I'm a data guy. So our new company, Adapt Your Life and Adapt Your Life Academy, adaptyourlifeacademy.com, has had several masterclasses now where we teach the evidence-based keto that I've learned and I've studied. And the goal of the academy is to improve people's health and quality of life, to eliminate confusion about the keto diet. Our strategy is to educate people, as many people as we can, about the keto diet, to help people get started on a keto diet as well. So we have 2 master classes at the moment, Keto Made Simple and the Stall Slayer. We teach people and we put them into a Facebook group to get them started for 3 weeks. And in the last 5 months, we launched it in November 2020. Here's a result of the survey that we did on the students who came into our class. The class itself launched in 2020, November, over 1,200 students in 2 cohorts. Oh, by the way, that ton of weight over there is how much weight we've had people lose during these classes, by the way, over a ton. So the third bullet, the masterclass consists of videos, print materials, and 3 weeks of a private group to get started. So we know there's a hurdle for a lot of people. They don't know how to start. They don't know where to go. We help with that first introduction of the information and to help people get started. The first group lost over 893 pounds, and the second group lost over 1,167 pounds, so over a ton of weight loss. I mean, this I kind of knew that this would work, but what's interesting is that 2/3 of the people who came in, or 3/4, 75%, had already been on keto for a while. They were trying to break a plateau, or what they were doing wasn't working anymore. And then 25% said they were just flat out beginners. But 94% said they learned something new about keto compared to what they had learned on the internet. And I'd like to show you the results of the survey. And these are the top 10 misconceptions about how to do a keto diet that were fixed by coming to learn the prescription strength. So I know there are a lot of ways to do it and they might work, but the method we use I know will work. And so we ask people, well, what did you learn? And what was different? So number 10, the measuring ketones was required. Many people didn't know that. You didn't need to measure ketones. So I'm putting it into here's what people thought, but it's not true. You don't need to measure ketones. We don't recommend that even. It just distracts people. Sometimes everything's working, but the ketones aren't there and you wonder what you're doing wrong. But wait, everything is working. So the goal is not to get into ketosis. The goal is to have it work for whatever you're trying to accomplish. Number 9, out of the 10, macro calculation was required. If you come into this thinking, oh, I need an app, I need to do that. No, you don't. You can learn a different way. And if it's confusing, it's time consuming. I've never put my own information into an app. That's too much work. So my patients have kind of helped me hone down a simple system because they're working and they don't want to just spend all their day putting information in a computer. Number 8, misconception is people thought medium chain triglyceride oil or ketone drinks or pills is what keto was or what keto is, so that you could be eating your regular diet and just take these, and then that's what keto is. Or if you do a keto diet, you have to have MCT oil, add it into your beverage and all that. No, you don't have to do any of this stuff. Now, some of this stuff can be helpful, but they haven't been studied in a way that I want before I will sign off and say, yes, it's to the level of FDA approval that these work and there won't be any unintended side effects. In fact, in my view, these kinds of things often give gas and nausea or bowel upset that I never see when I just use real food, or very rarely see people eating real food on a keto diet. So if you have stomach upset and you're following a keto diet and you're using these things, these may be the culprits. And you don't need those things to be on keto or a keto diet. So a lot of people came in thinking fasting was required. And if you go to certain segments of the internet, and that's where the only place you learn, sure, you can find gurus who teach fasting and books and beginner's guides and how many hours a day. And even there's the theory that autophagy is increased when you fast. And this has never really been studied in humans very well. Fasting is an advanced technique when the usual low-carb keto diet isn't working. So you don't have to come in here fasting, ignoring hunger signals. My teaching says eat when you're hungry. That hunger will fade away naturally, comfortably over time. You don't have to count the watch and say, oh, I can't eat now, I'm not in my window. My hunch, that while there's no study done yet, is that the autophagy happens because of the fat burning, because you're not eating carbs, not because you're not eating at all. Now, I haven't proven that, but the people who have studied fasting and autophagy have never studied low-carb diets. They've never studied the keto metabolism all day and eating protein. So my hunch is you're getting that anyway. Number 6, top mistake or myth or misconception, eating nuts is okay. Nuts, nut flours, and nut butter, these that will trip up the best of us. They're full of calories, and nuts make you want to eat more nuts, generally speaking, whether they're real nuts or legumes called peanuts. I mean, they're all kind of the same thing to me. They're hard to control. Even almond flour will trip up a lot of people. Just changing from to almond flour to no almond flour, going from net carbs to total carbs, can make things work. So be very careful, especially peanut butter can be a trigger food. I can remember the day when I would eat the whole jar of peanut butter. So and that's a trigger food if you can't stop and you eat to the whole thing. There are some times when I just won't have nuts around the house because they can become almost addictive. So this is a big mistake or misconception that nuts are fine. If you're having nuts, it's not working, try dropping them. You may see some results. Number 5, vegetables are unlimited. No, they have carbs. So even vegetables have to be limited. I was talking to someone recently who was doing great, but going to a buffet. I think it was a Chinese buffet, and he would get the meat and the veggies, but then he would get all more veggies and more veggies and more veggies. It wasn't working. So vegetables are not unlimited if you're doing a keto prescription strength, low carb keto diet. Just be careful of over consuming vegetables. Number 4, net carbs is keto and will work for everyone. Now, net carbs came about around the year 2000, 2002, had not been used before that time, and it has not really been incorporated into many research studies because we use the total carb method. So here you can see, and I have patients who are kind of tripped up by this. They look at the bread and they say, oh, look, 0 carb. Well, wait, 0 net carb. And then, so I teach people, look in the nutrition facts label on the back or the side. Don't take the marketing stuff. And here, oh, total carbs, 7 grams. So it's not 0. So not if you're using the total carb method. So total carb is stronger. It's the prescription strength. So if net carbs isn't working for you and you're using these other products, these other things, try the total carbs and it will probably start working for you. Number three, and we're getting close to number one, artificial sweeteners are forbidden. And this trips up a lot of people. They say, oh, even, that artificial sweeteners are worse than sugar. I've seen that on the internet. Show me the paper. Show me the data. In humans, sugar is worse. And so it's okay to have artificials. Well, even I say non-sugar sweeteners because stevia and monk fruit, these are not sugar, but they're natural. They're not artificial. They kind of, for me, they're just the substitutes to get you off the drug sugar. So I don't think there are side effects from these artificial sweeteners. A lot of people get tripped up by that, so they end up going back to sugar. What happens in a clinical practice, you teach someone it's okay to have something sweet without. So it's okay to have diet sodas. It's okay to have products where it's flavorful. You put it in your water and it gives flavor and it has no carbs. And what happens over time is you kind of lose the taste for the sweet things. And so most people will end up not having that very much. It was just really important to get you off that sugar. And in some cases, it's addictive for some people. So don't be tripped up by that. Of course, if artificial sweeteners give you a headache or give you stomach upset, don't have them. But many people can use them as a stopgap initially to get off of sugar. Number two, top two, now the expensive clean food is required. So you get on the internet, you learn about this, you think you have to have grass-fed beef, you think you have to go to the very expensive grocery stores and get the best organic kind of free range kinds of things. Go to the farmers markets. No, you don't have to do any of that. I mean, it's great if you can, as I mentioned, but this trips up a lot of people. They think it's out of their economic ability to do this. I've even had people eat at McDonald's off the dollar menu and get this to work. It's not my preference, but it was their lifestyle. I had to figure out how to make it work, and it can work if you do that. So the number one, drum roll for these thing that tripped up people, or they said they didn't know, basically before coming to learn from our classes, is that cheese, fats, and oils were limited. So that people think, in general, that cheese, fats, and oils are unlimited. You have as much as you want. I mean, there are no carbs, right? Well, so the clinical practice of using this for many, many years, and the way I learned this, had ironed out this already 20 years ago when I learned this, that you have to have a limit on, if you're trying to burn your body fat and fix diabetes, which involves getting rid of your body fat, which causes insulin resistance, you want to be sure to limit the caloric intake from these kinds of things, which means the amount. So we don't have people measure grams and things like that. We put a limit of ounces or serving sizes for these things. And on the far right here, the overconsumption of cheese, it's so common, and people think, well, I can have all the cheese. Look, there are no carbs in it. So this is a street learned sort of adding on to the keto carb counting that makes this work for many, many different people. So just be careful about the amount of fats. Don't add fats and oils if you're trying to lose the fat off your body. That whole idea came from enhancing the ketone level, which doesn't necessarily mean you're going to lose body fat. So being in ketosis doesn't mean you're going to be losing the fat off your body. And I know that's kind of hard if that's the first time you've heard that. So the internet-based versus evidence-based keto, I know that evidence-based keto is safe and effective when done right. Many, many studies about that. Keto works for virtually everyone when it's done right, with a few principles. And beware of the use of products or things, methods, apps and computers and things that might impair the success and safety of the evidence-based keto approach that we've carefully worked out through the years. So that internet-based keto can be not only confusing, it can be distracting, it can make it not work. And of course, the final bullet, if medical conditions are present, then if you have medical conditions, you're on medications, then monitoring for safety and for deprescribing, taking you off the medicines is essential. you need to be monitored if you do this. You're going to think that the diet's doing something when it's the drugs doing it. So do it with someone who understands how to do this. There are more and more doctors who know how to take you off the medicine safely. And so just please be careful. This is prescription strength sort of change in the diet, which is great, but it means medicines can become too strong and become unsafe even. So that's basically, as of the spring 2021, the current kind of themes on the internet, where it's great. So many people get success, and some people can use these methods and have success, but some people can't. So I don't want you to think that internet-based keto using these things that haven't been clinically tested means that keto itself, a different kind of keto diet, is not effective. Just try tweaking things here and there, or learn from some place that has the grounding in the first carb restriction. Protein comes first, and then your body will create its own ketones. Thank you very much. It's my pleasure to be with you here at Salt Lake, and I can't wait till we get back in person.
Okay, so first off, thank you so much, Dr. Westman. Fantastic presentation. A kind of a theme that we're getting during the presentations of this conference are, well, Amy really brought it down, kind of a no-nonsense and bringing things back to basics. So I really appreciate that. Well, number one, so the Adapt Academy. Now, you guys in the past have done some conferences. I'm assuming that once things get a little bit back to normal, you'll be doing that again?
Yeah, so Adapt Your Life at adaptyourlife.com started as a product company with bars, and we still sell them, but that's a tough road to hoe, as you know.
Yeah.
So, but we also then started to get into education, and pre-pandemic, we went around the country in the U.S. on Saturdays, and we were in meetings in let's say Loyola campus or in Scottsdale, or no, Phoenix, Tucson, Tempe, Phoenix area, and we brought in people who wanted to learn or were already doing keto diets, and then local experts. It was really fascinating, and that old saying of "you don't know what you got till it's gone." I really missed that, because we want to get back to traveling around, bringing people together. I mean, the emotions were high. I mean, you get stories of people who went from wheelchairs to walking, and you have people, crying in the aisles. Anyway, but also it's very evidence-based as well, with talks that talk about how to do it correctly. But Adapt Your Life, check out adaptyourlife.com. So the education stopped because of the COVID and that we couldn't travel. So we pivoted into a digital teaching platform. That's the Masterclass, and we opened the Keto or the Adapt Your Life Academy, adaptyourlifeacademy.com, in the fall of 2020. So we're really focusing on that, and that's where the survey came from teaching people through the digital class. And I get to meet, and right now we have 700 people who are all in one Facebook group and chattering, and we get to help them get started in the one proper way to do it. So that's been really exciting. So you can check out my informations, of course, at adaptyourlife.com, adaptyourlifeacademy.com. Also, drwestmanonline.com is a source of information where we do have that $9.99 page 4 available. Of course, that's all going to be shifted. It might be available from somewhere else soon. A lot going on. In fact, with my website, with the Adapt Your Life Academy, and unfortunately, in my clinical project that I was involved with for several years, kind of failed. That's the Heal Clinics. Heal Clinic no longer is in existence, but that was kind of a long shot in of the Virta Health idea of getting clinics and doing it, and among other reasons, it was just underfunded, and we weren't in Silicon Valley with 100 million of startup funds. So sadly that failed, but the Adapt Your Life Academy is going great guns. It's so similar information, and my passion is to teach. If I can't teach in clinics, we'll teach with digital master classes.
Nice. And that, well, the website and everything was another thing I was going to ask. What's the best way people can learn more about you? And so there's your website and the Adapt Academy and the Facebook group, right?
Exactly.
Okay. Let's see. Now, one thing that I noticed when, and this I've noticed this in the past, when studies talk about a low carb diet versus a very low carb ketogenic diet, those two things can be very different.
Right. Yeah.
I've seen low carb diets that are fewer than 100 grams or 200 grams of carbohydrates a day.
Right.
Now, some of the statistics that you were giving, were those like actual, like for realsies low carb diet, or just low carb in name?
Yeah. The way I see it is that so the powers that be that have databases of people doing diets think low carb is less than 30%, which might be less than anything under 150 grams of carbs for the day, which to me is really high. So, we teach young doctors that you don't want to look at percentages and things like that. Look at the number of grams of carbs per day. And so it's like a dose of a drug. The lower you go on the carbs, the stronger it is. It has more of an appetite suppression effect, and it means you're burning less sugar and more fat off your body. So I think of a low carb diet as anything under 100, 150 grams a day. But the keto level, again, that depends on the person. Some people will start to get into ketosis at 70 grams of carbs a day. That's if you're young, you're active. More people at 50 grams of carbs per day. But if you want everyone into ketosis, you want, to fix diabetes, obesity, medical issues, then you need to get people under 20 grams for the day. That's total, not net, and that's not per meal. It's for the whole day. Yeah. And that's the strongest prescription strength. So the definitions, we have in our paper in 2007, I'm the first author, we define these terms, but nobody reads our papers. And they find the latest Google thing and say, oh, there's no definition. No, there are definitions for these things.
Yeah, well, it's like you were talking about, back 100 years ago in 1923, they had it all written out exactly what you needed to do. And that's fascinating to me. How we've just come back.
They weren't distracted by the shiny drug. I mean, I have to think that profit motive and capitalism and is part of it. Yeah. I mean, you can't. So I mean, we learned that through the Heal clinics, that you can't make money by just telling people not to eat carbs.
Yeah.
I mean, you have to come up with a procedure. Because in the medical world, I should say, you can't make sufficient money. It's a big ante to get into that world financially.
Yeah. Well, and don't get me wrong, insulin and the discovery of insulin was just a life changer for people suffering from type 1 diabetes.
One fixed it. I know.
Oh, yeah.
Life. Yes.
But it is sad that so much of that knowledge was lost because something easier came along. And then I thought that was fascinating. The FDA approval for a phase 3 evidence for a low carb diet or a ketogenic diet. I mean, it would be approved. There's sufficient evidence there. That's amazing.
One reason why that kind of went off a light bulb in my head some time ago is that I used to do phase 3 trials for nicotine replacement.
Oh, really?
For smoking cessation. So I was in that world in a different content, a different domain of knowledge. Yeah, I actually worked with the inventor of the nicotine patch for about 10 years, and brilliant mind. And the process for approval of drugs kind of it's what we all sort of did studies for. And now there's no process for diets. So I thought, well, maybe I can take what I learned before and give that sort of certainty for people, and they'll feel more comfortable about doing a low-carb keto diet.
Yeah.
So, the skeptics will say, well, I never trust a drug when it comes out of FDA. Okay. Well,
Liz didn't even need to go through it.
Well, and I've kind of learned you don't want to be the first one to take the drug. You
Yeah.
want to let other people test it. But, but if it's a condition that's really serious, I'm joking. Of course, you want to take an approved product.
Now, the first time I ever saw you speak, by the way, was at Low-carb San Diego back in, I think it was 2018. And you said something that was really interesting up there on the stand, and it actually stuck in my head. You said that everybody talks about artificial sweeteners spiking insulin as if there was clinical research proving that.
Right.
And you've never seen that.
Still haven't.
Okay.
So there's a study that gets misconstrued, overgeneralized, where in combination with carbs. So I'm a purist that I want people to study our situation, not other situations, and say therefore it's going to happen, because we've seen that has been wrong. I mean, it's kind of like saying if we go to the moon, we're going to assume gravity is the same. Well, wait a sec. There's not as much gravity, right? You can leap and a golf ball goes a mile or something. Yeah. So I'd like to see that study. And even, I've been on the same podium with some of these doctors who say insulin spikes when you have artificial. Show me. Yeah. I mean, I will value one or two people, or even if you're well-intentioned, you have your own information and you post it on YouTube or you send it to one of us. I want to know, because if it does happen, it's probably rare, and I still kind of hold out. An animal study is not good enough. I need something in people, and ideally more than one person.
Yeah.
Have you seen that information? Okay. Are you aware of any?
No, I've never seen anything. I've seen other things related to artificial sweeteners, but nothing that has anything to do with insulin.
Yeah.
It's remarkably difficult to measure anyway. But
well, that's right. You can't just get an insulin meter. Right?
No, that would be cool, though.
Yeah.
I don't know if you're aware of it. There's a Twitter account called Says in Mice, and he likes to retweet studies. And all he does is he has the inflammatory headline and then says, in mice. Because he's taking these studies that are rodent studies that, big news, such and such does blah, blah, blah. And then he says, in mice.
Yeah.
Anyway, now you were talking about food quality and stuff like that. I don't know if this was you that said it, but it might have been you, was talking about how ground beef and mustard is a perfectly okay way to go.
Sure.
Because I think that, Dr. Ballerstedt talks about his the barrel and how the shortest stave is what limits things. Oh. And the grass-fed panda massaged beef that you get at the local farmer's market is not your limiting factor. In this case, it's getting the right food. And ground beef that you're cooking on a camp stove and you're putting some mustard in it it's a good step in the right direction.
Absolutely. Yeah. Again, the basic knowledge that I want people to understand is that protein comes first. Yep. And you don't really ever have to eat carbs. I mean, if you do eat a lot of carbs, you have to burn them, and you can't burn your body fat. So most people come to me they want to lose weight, they want to lose their body fat, and just that simple teaching often sticks. So, if you drink sugar, you have to burn sugar, and you can't burn fat. Yeah. So the other kind of thing that I want people to know is ketones come from your body fat just fine. You get into ketosis without eating ketones and fats and oils and things like that.
And it's free. And that actually brings up a different, another thing about protein. And so you advocate for getting good protein that it's going to come along with fat and calories. Do you see in your clinical experience a minimum amount of calories that going below that will cause problems for people?
No.
Okay.
No, that's this internet or belief out there that, am I eating too much, doc? Or excuse me, am I eating
too little?
so that my see, it doesn't even, I can't even repeat the it's so wrong. No, the way you lose weight is by eating less, not more. I mean, think about it.
Yeah.
So I think this comes from the apples and oranges sort of. If you're using a diet that has carbs in it, and you're changing, from 1,500 to 1,200, which is a minor change, you might get a reduction in your metabolic rate that is more than that change in caloric intake. But we don't see that to be clinically significant in those who are not eating carbs. So I think it's one of those things that, look, you can say that if you're eating carbs, I'm not going to dispute the science. It just doesn't apply here on the moon.
That's right. And one other thing. Well, first off, I'm really sad I can't eat as much cheese as I want.
Well, you might be able to if you tweak things. But I mean, as you want means, you have copious amount. Me too.
Yeah. And the last thing I had was, I just wanted to point out, when you were talking about working with a medical professional to prescribe medications, how amazing is that? Is there any better non-scale victory than having to take fewer medications because your body has taken over and is doing what it's supposed to?
Yeah, my most grateful patients are the ones who are no longer checking their blood sugar, and they're no longer taking insulin. And right now, so insulin doesn't fix things; it manages. And the language is right there, right in the open. TV, the new drug, manage your. So eat anything you want will help you No, if you just change what you eat a little bit, you don't have to have diabetes at all. You don't have to manage it. And so the first level of insulin is called U100. That's 100 strength. Now there's U500.
Oh, wow.
Because people were injecting so much volume of the insulin that they couldn't do it. So they just made it more concentrated. So 1 ml or 1 cc of a U500 is the same as 5 ml of the 100. So they're making it more and more concentrated, which doesn't fix the problem. Your body just fights it even more. And so just recently, I have someone who's almost off the U500, which people say, oh, it's so strong, you can't change. Yes, you can. You can deprescribe even off that. And she just, by herself, she said, well, but my blood sugars, they're not normal, but they were a lot better now than they were on the U500. So even, she's able to see that there's such an improvement, and this is within just a few weeks.
Wow.
So she's been on this for years. So that, be careful. If you don't try to do this on your own, if you don't know what we're talking about. It really, the Virta Health study is just fantastic to document that in a way that even, word is on the street that some insurance companies and all are trying to try Virta Health out, which is fantastic.
Really?
Yeah. So,
well, it's a good thing that insulin is so cheap, right?
Well, and that's the worst. You don't want to make insulin cheaper and make blood sugar monitoring easier. You want to make it harder.
Or less necessary. How about that? Yes. Okay. Well, thank you so much. It's been a pleasure. I hope to see you in person soon.
Oh, we will, and hopefully those cruises will be back. I get to enjoy your whole family, and again, thanks for everything you're doing for the keto community and helping people's health. I appreciate that, Chris.
Thanks back to you. Have a good day.